Well, good morning and welcome, everyone. Our session today is optimizing financial and operational performance through data. I noted there are some in the room that have worked with me in the past, and they know firsthand what the value of that data brings. So I worked at Core Healthcare here in Milwaukee for most of my career. Also worked at Alexian Brothers Health System running their capital supply chain, and then worked for a couple of software companies currently with Phoenix Data Systems.
Hi, my name is Chris Funk. I work with PointCore, which is a wholly owned subsidiary of OSF Healthcare out of Illinois and then Upper Peninsula. We've got about 17 campuses. I come from clinical engineering, and like Al said, data was very important for me and for our team to help with capital planning and maintaining our operating margins. And because no good deed goes unpunished, I am now the manager of the data intelligence team to take these solutions to other IDNs as well as the other verticals within our organization.
So the objectives for today is to first understand what data to collect, how to clean your data and keep it clean, and then we'll demonstrate leveraging data to optimize productivity, cost effectiveness, and increase value and recognition. So the presentation today is based on three premises. The first is you can't manage what you don't measure. What gets measured gets improved. That was a quote by Peter Drucker, and that's absolutely true. The second is, do you know what you don't know? And for many people in our industry, they don't know what they don't know, and it leaves them open for a lot of inefficiency. And lastly, once you do know, that awareness inspires opportunity and gives you a good idea of where you have opportunities for improvement, and then go after those opportunities and make those improvements across the board, improving year over year. This is a slide that I incorporate in just about every one of my presentations. It was an HTM and HFM maturity curve that I developed many years ago with my teams. And if you look at the lower left-hand corner of that maturity curve, that's the very basics. You're a PM break fix organization, what I often refer to as the price of admission for working in this industry. And if you can't do that well, then you're not going to be around very long. But if that's what all you are providing, then you're looked at often as a cost center, necessary evil, maintenance or repair focused, reactive and firefighting instead of being proactive, and only focused on point solutions, which is just what's right here in front of me right now, versus a future state of being a customer focused service business, recognized as a valuable part of the organization. You're generally then involved in capital planning and things that really move the needle and save big money for your organization. And there's a path to get from one to the other, and it starts with data structure and data integrity. And that often people equate that to cleaning up their device data, manufacturer model device category. And while that's true, there's so much more to it. Cleaning up your CMMS codes. When I first started this, we had over 150 codes in our system, because over time you create codes to do a specific thing and they never go away. And what it got to was I could likely have 20 different technicians doing the exact same work and coding it 20 different ways. So how can you ever measure anything and understand what it is that's going on? And then once you get to the point where everything means the same thing everywhere, the next step is centralization and standardization of policies and procedures. So you get to the point where people are doing the same thing everywhere. And this is particularly important in multi-hospital systems, okay? Because if you don't have that, then how can you hope to do any benchmarking? And if something falls outside a standard deviation from the norm, how do you know what that actually means, right? Once you have those two in place, then the next is you can develop key performance indicators from that data that you have. And I always promote that you advertise that, you publish those KPIs both to your executive leadership and your customers, so that they know what to expect from you. And what that does in step 4, it increases your visibility and accountability within your organization, something that you really want to have. And then lastly, customer satisfaction. That to me is, if I boil it down to 2 KPIs that you should focus on, it's cost of service ratio and customer satisfaction. If you nail those 2 things, everything else kind of takes care of itself.
Yeah. Speaking of taking care of itself, 1 and 2 are really the biggest focus there, because if you've got standardization down and you're controlling the processes, 3, 4, and 5 tend to fall right into place. So your biggest challenge is going to be that initial push. But we found 3 and 4 and 5 actually really just kind of roll right off once you get the 1 and 2s done. So to provide some context on that, our organization is constantly growing, like many others. If you're not buying other hospitals, you're being bought. Because I come from a Catholic nonprofit, our sisters also have a bit of a bleeding heart. They like to take on the entire new staff, thin out our operating margins. If somebody's going, bankrupt, we're going to save them, because we want to make sure we've got all of our critical access available within Illinois. So the big challenge we've had is, like any others, brand new sets of inventory, neon code-ins, 30-year-old exam tables, just trying to keep up with what do we have now that we purchased this new facility, and what does it look like, and what can we expect from it? How do we staff it? Some of those basic questions. We've got some supervisors that are pretty good in Excel that come up with numbers, but we don't really have a lot of data to support that. So some of the things that we're always challenged by: capital planning, siloed data. We've got Premier data, we've got IT data, we've got our CMMS data. We need to figure out how to put that together and start making more data-driven decisions, which is a little easier said than done. And some of the powerful questions that have flown my way over the years, what should we prioritize for replacement? What's our risk if we don't replace this? Our sisters like to run everything till the wheels fall off. I mean, we take the AHA standards and basically add 20% to that. A lot of our vendors don't necessarily think that MRIs should last 15 years, but I mean, they expect it, so.
All right, so let's cover what data to collect. First is device data. Obviously, in our inventory, we should capture everything related to that piece of equipment, manufacturer model, device category, serial number. But nowadays, I mean, if you're not collecting cybersecurity data, all the network information associated with that, there are very few devices today that aren't networked, right? So that's an important aspect to capture as well. But then, as I said, there's work order data that you should be capturing, and within that, both device and non-device work orders. I know many organizations that the only thing that they document are some only PM and not even CM, which is crazy to me. But many also just PM, CM, and don't document the rest of the work that they do. And I always liken it to creating a personal budget. Okay, how do you do that? Well, you start by identifying everything that you're spending money on. Okay, no judgment about it, but now you know where all your money's going, and then you can analyze it to see if that's where you want your money to go. So you find that you're spending $200 a month on subscriptions that you never use. Probably don't want that, right? So by capturing all of the data, you can now determine what does good look like, and ensure that your tech time is going to where you want it to go, okay? So time and labor costs and material costs, I'm finding in this industry, there's a lot of holes in that data. So, Chris talked about getting involved in capital planning. That's an important component of that. And I would question, if you're not doing all of that documentation, how accurate are your equipment records? Probably not very accurate. So it's critical that you capture all of that. Contract data. I'm surprised at how many people, and I've seen it even in my own organization, where they spend time and money repairing equipment that's under full service contract. Quick story, I consulted with an organization And I had a list of all their contracts, and then I interviewed the technicians, and these two gentlemen were in front of me. I said, "What do you guys do?" "Well, we fix infusion pumps." I said, "Well, I understand you have a full service contract on your pumps. Well, so help me understand that." "Well, we get rebates for all the work that we do." "Oh, okay. And how much were your rebates last year?" $30,000. I'm guessing that between the two of you, you make more than 30 grand a year. They're like, "Oh, yeah." So, I mean, there's that kind of stuff that goes on. So important to have contract data, and so that your technicians understand what is under contract, what the levels of those contracts are. Um, Financial data. If you don't stay on top of where all that spend is going in keeping up your equipment, you can't hope to capture cost of service ratio and assess that, which is critically important. But also, I'm guessing that anybody here in management has their bonus, if you have one, tied to meeting your financial objectives, right? So you better keep track of that. And then lastly, and probably most importantly, customer satisfaction data.
Yeah, I got to one up you on the contract. When we were doing cleanup in that area, we found a device that had been retired for 5 years that had 2 contracts for full service on it. That was an interesting call to the vendor. They're like, "Well, nobody ever called us, so we just kept charging you." All right, cleaning data.
So here's an example that was within my own database. So this is real. This is for an AMX 4 Plus. So first of all, manufacturer. Within the database, there were 19 different representations for GE Healthcare. Okay, only one that should have been on the model. Okay, so here's a photo of the actual manual that tells you from a model perspective. You know, it's an AMX 4 Plus, but you know all these different models that you could represent, and there were 8 different representations of the model within the database for that one device. Okay, and device category, 17 different representations of that same device. It's insane. And it's funny when I stand up in front of a group like this and show these things, a lot of heads nodding. Yep, that's exactly what my database looks like. And it's crazy. So you can classify that device in over 2,500 different ways. That is insane. How can you ever expect to be able to run accurate reports if that's what your database looks like? To use or not to use, you've got all of these different sources to pull from to standardize your data. Okay, and you know, those that worked with me in my past, we had a very extensive data integrity policy to define all of this stuff. Here's what the nomenclature is going to look like. You know, plurals or singular, commas. At the time, we used UMDM DNS, but there's a push toward the FDA's UDI. So
good idea.
Go to the next one, Chris. So you know, here's an example of that, and the good idea. The UDI is similar to like your automobile VIN number, right? So a lot of good information contained in that. So it kind of makes sense to move in that direction. But at the end of the day, pick something and go with it. Chris?
Yeah, so when I came in to HDM and took over the database 5 years ago, we had a lot of unique processes. Techs weren't allowed to put in assets. We had 1,000 asset backlog in an email with handwritten forms. There was no control over those modalities. Very similar to what Al said. We had for this OEC 9900, I think we had like 9 different versions of it. We had manufacturer OEC. We had 3 flavors of GE. So that cleanup took about 2 years, you know, on the side. But the first thing that we wanted to do was just lock down whatever that hierarchy is in your database. We use AIMS, so we're able to control the data managers. The clinical engineering team took over manufacturers, model numbers, model names, and then we started requiring pictures of nameplates. So when the tech would come out, they wouldn't have to think about it. They wouldn't have to know what we're calling it this week as we're doing cleanup. They just need to take a picture of the nameplate. They could tag the asset. They would send that picture to us. Or if you've got a CMMS system that has attachments, you can attach it there. It would go into a pending process. We would do a workup, ensure the PM schedule was set correctly on that. We would identify the model number, model name. And then one of the really important things for capital planning is life cycle info. We started capturing the born on dates, manufacture dates. We also opened it up for best guess. One of the things that you're going to absolutely have to have if you really want to do a good capital planning process is knowing how old your equipment is. And for the stuff that's 30 years old, you can kind of ballpark that. You don't have to get it down to the day or anything. But since 2014, that's something that's been on all those nameplates. So part of capturing that and training your techs to get the right model number according to the manufacturer will also get you the ability to start aging out your equipment. And I'll show you what that gets later on. But at the end of the day, standardize. Doesn't matter if it's right or not. One-to-one relationships or many-to-one relationships. We have all this wonderful tech out, AI, we've got NLP, we've got machine learning models, but it has to have standardized data. You've got to have enough data and it has to be standardized in some form. Even if it's not the final right form, as long as it's lined up easy, it's really easy to update in mass.
One other thing I want to call out is I'm just curious, how many in the room are confident that they have 100% of acquisition costs loaded within their database? Two? Huh? Acquisition costs, yeah. So it was interesting. I attended an MD Expo a number of years ago that Dave Francoeur put on, and I asked that same question. The presentation was on cost of service ratio. And I was like, so I asked the same question, and I said, how can you calculate cost of service ratio if you're missing one of the two key components to calculate that? So another piece of information you better be capturing.
Yep. I still think you can capture that for those devices that are 30 years old. We had a checkbox that said the cost was estimated. So we would put a cost in there because we just didn't know back then what they
yeah.
But we just checked the checkbox and we kept track of that. But to get your COSR, you better put a cost.
Yeah. So we had a three-tiered approach. And so we got to the point where we got the PO from purchasing whenever we got a new device in. So that was number one. But that's not always possible. You're acquiring new hospitals and their database is a dumpster fire and you don't have that. So how do you get that information? The second source of truth then was if I have a like model in the system with actual acquisition costs, then we use that. And then the third tier was the average cost for that device category. Was it 100% accurate? No. Was it better than zero? Absolutely.
Better than zero is great for many organizations. We actually tweaked that a little bit. So for our capital plan, we use estimated replacement cost because it doesn't really matter what you paid for it 3 years ago. It's what you're going to have to pay to replace it now. With COVID and some of the other things, we've seen prices go up. Tariffs are going to make prices go up. So we try to farm the metadata and find a nice conservative middle, for that, like the Outback, not the stripped down Subaru Forester, but we want to be able to project what that cost to replace your fleet is going to be. And even if you're a little high and you got money left over, that tends to make people happy because then you can buy a couple other things with that.
I've had many debates with Bin Sing Wang over the years about the validity of cost of service rate, because we don't have any standard for that. It's like, do you use your real acquisition cost? Do you use a list price? And it's like, to me, I don't care. It doesn't matter, because what you're trying to do is set a baseline, continue to measure it the same way, and then target improvement year over year.
Yeah, as long as you don't change your denominator every 3 months to make it.
Okay, so the pre-work to cleaning up your data: review your data integrity policy. If you don't have one, create one. The one that we created was quite extensive. As I said, it's like an 80-page document, but the first page of that document was a policy statement that said, had a paragraph in it that said, failure to comply with this policy will result in disciplinary action up to and including termination. So it sent a message to our team that we take this seriously because we have to. If we want to improve, if we want to deliver the optimum level of service to our customers, we have to have good data. Okay, but this is just one sample of it. This one, back up. So it happens to be device category management. It has a definition of what that is, the data format for that, and then different sections on how to do things, who's responsible for it, what that process is. Next is to verify or identify responsible parties, who's going to figure out what to call things and make the changes in the database. So we have a governance group that if a new device was added, then we never wanted to stop technicians from doing their work, right? But it would flag that thing as new because it didn't already exist within the database, and then it would go to this governance team to determine what is that thing going forward. Get friendly with Excel, VLOOKUP, highlight duplicates, remove duplicates, filters, set timelines, and dedicate work to this in 2-hour chunks with limited interruptions. Don't sweat the small stuff. End goal is to remove duplicates. I will tell you that this is not a quick and easy thing if you do it yourself. I hired a college intern for an entire summer and paired her up with the data analyst that I had on my team to clean up our database, both inventory and codes. That was not an inexpensive venture, but there are other options.
Yeah. Ones that don't include Excel nightmares.
Right. And so, Phoenix has superior analytics that can do data cleanup. And this is a typical outcome of that, which can be turned around in a matter of days. Usually what we'll start out is about 25% of automated cleanup, and then the things that take a little bit more research to clean up takes a little bit longer, but where we typically end up is north of 80%. And the reason it isn't higher than that is because you've all seen the data where there just isn't enough information there to even give you a clue of what that thing is, right? So then it goes back to the customer, say, you got to go put eyes on that thing, and using these rules determine what it is.
Yeah, so I built my team to focus on trying to engage with some of the newer technology coming out, and one of the first things that we jumped into was looking at natural language processing. So indexing between ECRI, UMDNS, between our 17 different campuses with a plethora of different devices. And really, this was kind of the story for me when I first started. We had about 20,000 unique make and models. 5 minutes is a pretty good ballpark. 10.5 months, 40 hours a week. I mean, and if you did that, you'd probably go crazy. So it would definitely take a little longer. But with NLP, we're able to run a first wave and identify those manufacturers, group those up together, and we've got some really, really amazing outcomes out of that. We've been able to streamline that down to just a few days for validation on the outliers. But again, you have to have some form of modality standard. If you've got 7 different models with 7 different, because they're doing parent-child, and that technician thought they were doing the right thing, but maybe they grabbed the wrong nameplates, it does create bad data for your model, and your model will learn bad data if you give it bad data. So there's still some cleanup that has to happen as well.
Chris, the nameplate pictures, are you attaching that to the asset team?
Yep. Yeah, Ames has a pretty cool feature with that on the phone. The techs are able to scan the asset tags as well. So we kind of made this like let's redo our HTM inventory. We got some custom asset tags that have the 2D scannable. So you got a little, something new and fresh. It's got our logo on it, and we sent them out to do a full inventory, top to bottom. It took about 6 months, going from facility to facility. But as they scan those new tags in, they can take that picture and attach it right to the device. Really, really beneficial for us, because then we don't have to have a reference catalog to say, all right, if you see this model, this is what you call it. We set it for them. They don't have to worry about it. They love it.
All right, so let's talk about how to optimize productivity using your data. So as I mentioned earlier, it's important for you to document everything that you do. And then we subcategorize the work order data into device hours and non-device hours. So the device hours, as you can see, there's a list there of typical work that's done and documented that's related to taking care of a device. So scheduled maintenance, corrective maintenance, incoming inspections, incident investigations, hazard alerts, recalls. And then there's non-device hours, department meetings, compliance training, vendor training, admin work, travel, et cetera. Okay. I'm not dictating to you what these are. You decide what they are, but again, make sure that you're documenting everything that you're doing. I found it interesting when we first did that, and I surveyed a lot of people in the industry to determine that on average, device hours per technician, 1,000. Think about that for a minute. Out of 2,080 hours, less than half of your tech's time is spent doing what you're actually paying them to do. Okay. So by doing that, you can look at, are there ways that for me to optimize the device hours and minimize the non-device hours? And I'm not saying that the stuff on the right isn't important. When we first started this, we called it productive and non-productive time. And I didn't like that because presumably everything on the right is still productive, right? But the other thing that I always like to call out is if you look at these two lists and you ask the question, what do technicians love to do and what do they hate to do? It's the stuff on the left that they love to do and stuff on the right that they don't really care to do. And so not only do you improve productivity, but you also increase employee engagement at the same time, right? So let me give you some examples. Department meetings. So how that typically works is people start to congregate about half an hour before the meeting, and then the meetings often you go down rabbit holes and they tend to run long, and then people will hang out and shoot the breeze for half an hour after the meeting. Okay. And so we started creating a very, very crisp agenda for our meetings with a time allotted for each topic. And if things started to go down rabbit holes, we would put it in a parking lot and assign it to an individual, a group of individuals to take offline, come up with a solution, and bring back to the team with a recommendation. Okay. And so we were able to cut our department meetings down considerably and got more done with them. You know, training is important, but some of the admin work, I would venture to guess that everybody here that's led a team has seen time dumped on work orders because they feel like they have to meet a certain threshold of documented hours.
Exactly.
Yeah.
You're gonna get exactly what you asked.
Well, that's the thing. And
Locating devices.
I've told people, don't ever set a threshold. Don't do that. Don't say, I need you to document 7.5 hours per day. You will get that, just won't mean anything, right? Because people are just going to add time to each work order to come up with that. All I ever told people is just document everything that you do. And if I find that Chris is consistently coming up with, 5.5 hours per day, then I'm going to find more stuff for Chris to do. But it lends itself to getting accurate data, and to me, that's more important.
Justify more FTE or take on more service contracts. It's great data.
Yeah, it is great data. Go to the next one. So this is something that that we ran from anonymously with several of our customers, but this is one in particular, and the ID number in the first column is actually an anonymized technician. Okay. But if you look at the weeks that they worked and average CM, average PM, and then non-device hours. But look at the column all the way on the right that indicates the average undocumented hours per week. Some like the one that's 1.32, pretty good, right? But 19 and a half, a couple of them north of 30. It's like, what are you doing? So I think this is an important thing to, when I tell people where to start, because a lot of times people start down this path. Okay, what foot do I put in front of the other? Where do I start? Start by making sure that everybody's documenting everything that they do. Okay, because once you have that data, now you can start to analyze that data and determine what does good look like.
Your best performers could be in the red, and some of your worst performers are always in the green.
Well, Chris, that's a great point, because I had some of my top imaging engineers push back on me and say things like, well, what do you want me to do? My paperwork or take care of my customers? It's like, I need you to do both. And you'll see as we go on here what value that brings. So over time, having focused on increasing the device hours and minimizing the non-device hours. Again, we started at 1,001, which was the industry average, and by year 4 we were at 1,399. When I left that organization, we were at 1,550 annual device hours per technician. Now think about that. Think about how much more you can accomplish at 1,550 versus 1,000. And again, you're not browbeating people. You're helping them become more efficient and doing the things that they love to do. Okay, so it's an immense benefit.
And ensuring they justify their existence too, because you could be the best at customer service and do your job great. If you don't have any paper trail to prove that, well, somebody above you is going to make a decision one day based on the data they have. So when it comes to capturing this data, we've tried a few different things within our organization, and honestly, if you're not checking on it daily and weekly, it's just going to pile up, and then you'll have that at the end of the month report. Director's going to yell at the manager's going to yell at the techs, and the techs again are just going to phone in hours just to make up what they need to do. So one of the things that we did was we put our data into a neural network that allows us to pull in time card data, EMR data, other fun stuff. But we created a very specific dashboard for our techs, because our techs are the baseline for all of our data. An accurate inventory, the right manufacturer model from the nameplate pictures they're taking, the manufacturer dates, and that total cost of service. We want to identify what these devices are costing us so that we can use that as part of our replacement strategy. So we built a dashboard for the techs that allow them to look at all of their work order hours, their non-work order hours, very much similar to what Al just showed, overtime, PTO, and then even the number of work orders they touch a day. So we give them a little bit of this is your hours per or touches per hour. That allows some of the supervisors to compare like technicians, right? Everyone's doing things differently. You've got your anesthesia, your ventilator techs. They're not going to be touching as many work orders, but if you've got a shop with a couple people on beds and stretchers, you can kind of look at them and see who might need some additional training or who might need some upskilling. So, and of course, the important thing here is we want this data to go back into the database and be clean. So we developed hyperlinks that allow you to go right to your AIMS work order. AIMS 3 is browser-based, so we were afforded that. So again, they can drill down, they can find out where they might be missing hours. They can see their non-work order through Hammer Time, and then they can see their work orders. Once we have this, we start piling up the hours. You can kind of see from the increase in graphs that we've been acquiring more and more facilities over the years. We finished up a proton beam 2 years ago, and the sister said, hold my beer, and we got another 2 hospitals within a year and a half after that. So yeah, we're just not slowing down. It's getting crazy. This is where we really need to identify what our effect is on the operating margin and justify our existence, because cuts are going to be coming across all departments, and the more we've got to back up, the better off we are. And then to echo Al's, device hours per tech. So a lot of shops traditionally like to use asset counts. Well, as we're able to start parsing out by model what we can expect from a CM or a PM, we can really see where the complexity of that device averages out a lot more time, right? So if you've got a clinic that's got 3,000 sphygmos, do you really need 2 techs for that? There are no PM. There's really nothing to do other than the inventory, right? So those device counts can mask your numbers, but what we found is that it actually shortchanges your staffing. If you look at a lot of complex equipment, even with all that minor equipment that's really not going to cost you anything, with our current inventory, we would justify 78 techs, and that's at 1450, which is like right up with Al's Jason Bourne and John Wick techs. So per 1250 devices, you'd get 74. So you find that the pushback you get from the managers on looking at the hours versus the counts tends to go away once you show them, well, you'll actually get more if you do it this way. But you gotta capture the data first.
So from capturing the data, we were able to determine by device category the number of devices that we had in that category, the hours per device, and then the total device hours. And then from that, this is a report that I generated for finance every year at budget time. So we had we identified the net adds to our inventory. So it took into account the devices that we had retired, and then added back in the devices that were added to the inventory, both by count and then associated hours to support those devices. And you can see down the bottom, it shows in inventory growth. We averaged 10% inventory growth year over year. But we were able, with this document or with this report, to show, all right, here's what's added. The stuff's not going to maintain itself. And this is key, to be able to show that with an organization sanctioned productivity model, we were at 100% productivity, which made it clear we couldn't absorb anymore, right? So what do I do with that additional inventory? Well, I can outsource it for this much, or you give me the people that I need to support it in-house for this much. What would you like me to do? Never, ever did I get turned down for needing additional equipment out as well. So if you look on the right, well, this is broken down by region, because we had 5 different regions within the organization. And I wanted to identify what the ads were in each of the regions, because we did allocations back out to those regions. But then a total number of FTEs, and we also broke it out by modality. So I knew if I needed to add people, where do I need to add them? What type of engineer did I need to add to the system? But the divisor for those at that time was, if you can see in the middle portion, was 1,230 annual device hours per technician. If you're using 2080 as your divisor, you're cheating yourself, because you're not going to spend 2,080 hours working on equipment, right? So you have to know what those device hours are and use that as your divisor. But when I presented this, the conversation I would have with finance is, okay, this is based on 1,230 hours, but we've made productivity gains and increases in annual device hours per technician. So today it's at 1,350 or whatever that number was. So instead of 5.32, I can name that tune in 4, right? Do you think that garnered some credibility with my finance team? Maybe a little bit. The other thing I want to call out too is that I never ever used data as in a punitive way as a tool to beat up technicians, ever. All data is an indicator. Okay, so for instance, I found, looking at the data, that Chris spent 30% more than a standard deviation from the mean to PM this particular group of devices. Okay, well, it could mean that Chris's padding is hours on that, or it could mean that Chris has learned that if I do these additional steps during the PM, I'll reduce my CM. And if that's true, don't I want everybody doing that? Okay. Similarly, I find that Dave is 30% under the mean. And could it mean that Dave is skipping steps that he shouldn't be? Maybe. But it could also mean that over the course of his travels, Dave has learned a more efficient way of doing that and doing the same work in less time. And if that's true, don't I want everybody doing that? Okay. So that's, again, data is just an indicator that allows you to peel the onion and determine why. Why is it outside of that?
Cost effectiveness.
So from a resource planning perspective, if you have the data and you understand, let's say you've got a variety of different manufactured models of the same device within your system, and this is data that we can also provide. It can show you over the course of a year what it's going to take. So if your organization is going to replace an entire fleet of pick a modality, to have this data is key to understand what's that going to mean to me relative to staffing and hours, right? So if what you see is this device that they're looking to buy is going to take more time to support, you should know that so that you can vie for that additional staffing that you need. Or if it's less than, all right, how can I apply those hours elsewhere? It was interesting. I had a discussion with a technician once that he says, I know why you're doing all of this stuff. You're looking to get rid of some of us. I'm like, do you have any idea how much opportunity we have that we don't have the bandwidth to go after? I'm not ever getting rid of anybody. In fact, oftentimes when finance came through with their broad brush reduction in workforce initiatives, people in other departments that lost staff would come to me and say, how many people did you lose? I was like, none. What? In fact, I added two. What? How is that possible? Well, because we had the data.
Good records.
Yeah. Yeah, failure rates. This is a key. Most AEM programs are based on failure rates. So it's important to have this information so that you can determine and present to a surveyor what criteria you're using and where that data is coming from to support your AEM program. Expenses, financial information is one that I said was key as well. And here, looking at supplies, if you look at the bigger numbers, you can quickly identify where your opportunities are to reduce your costs. And go to the next one. And here too, other expenses, look at where my big numbers are: maintenance and service contracts, parts, maintenance and repair, x-ray tubes, outside service, clinical engineering, and maintenance. So that's where a majority of my expenses are going, and I can look at how can I reduce those. One thing that we did having the data is we created a glassware projection tool so that we could predict with a fairly high degree of accuracy when our glassware was going to fail, and then we could negotiate with the OEMs on buying that glassware at a significant discount. If you do that versus waiting until the thing fails and then buying it, you're not going to get any discount on that. So like I went to Toshiba, I said, if I buy 5 CT tubes this year, what can you do for me? You'd be amazed how much money we saved.
Yeah, so capturing that data from work orders, having that accurate inventory, once we start putting that together, not only can we forecast once we inventory and acquire a new hospital, what we're going to need from a tech standpoint, we can also kind of see what to expect from a cost standpoint, be it preventive maintenance, corrective maintenance. So doing some machine learning on our data has allowed us to essentially project based off life cycle year. And as you can see over the years, the big hump post-COVID, prices just keep going up. So the fleet manager solution we built essentially puts those two together. So we've got service costs, we've got life cycle info. We're scoring assets based on life cycle. We're taking into account end of support. We're taking into account physical condition, utilization. We can bucket now these inventories, and we can start to visibly see what our fleet looks like, right? So finance hears from everybody. Oh, we need this, we need that. Respiratory is always complaining. Physical therapy, they just do what they do. They got duct tape and a welder, and they're going to keep on with 30-year-old equipment. Laboratory usually runs a pretty good ship. They cycle out. They've got good relationships with the vendors, but we don't know where the gaps are. We don't know how far behind we are. Right? We always know that we need more to do more with less. But what our current status is? How far behind are we? So seeing this data can really start some good conversations. Bucketing up your modalities into certain classes, so it makes it a little easier for the C-suite to digest, but really trying to plan out what that next 5 years looks like and how we can afford that, right? Standardizing your fleet is the first opportunity. Buying in bulk gets you savings. Training your float staff from multiple hospitals. If it's the same equipment everywhere they go, it's easier for them to use. Better for patient safety as well. Easier for your technicians if you know one type of infusion device that you have to train on, as opposed to 4 different, manufacturers, right? So you get larger parts purchases, bulk purchases from a capital standpoint, just savings everywhere. So now that we have the life cycle too, we can also show where we're going to fall off the cliff, what's going to happen if we don't change. That's the biggest thing. It's, this is great. We're really far behind. We know. What do we need to take care of now? What's our biggest risk from a safety standpoint, from a cost? What are we going to have to pay just as much to replace to keep it running for the next year? With that kind of information, we can start doing a 5-year plan. We can create a bucket for each year. We can move things around because, as soon as you get a capital plan sorted out, something happens, right? Everyone's got a plan until they get punched in the face. Last year for us, that was Air going up, right? And the 110 ventilators, high acuity ventilators that we had just bought during COVID were all of a sudden into support within a month. So all the plan we had for that year, all that money, that millions of dollars, just instantly had to shift over to replace that need. Finish it up, yeah. So this is essentially the outcome for our HTM department with our capital planning and fleet manager, to be able to visualize this data, to take this to our financial team, our leadership cabinet. First year, they saw how bad things were, and they gave us some extra money. So they gave us $5 million. That's a lot. You can do a lot with that. We took that and we got an additional 1.6 million in devices by leveraging some of the ECRI bargaining tools. MD Byline has similar ones, better negotiating, and then targeting a plan where we bought in bulk. Now, we used our capital tool not just to identify our reds and oranges and the bad things, but we also found the stuff that was kind of middle road, and we could reallocate that to a hospital that might not be getting the replacement soon. We also found a bunch of junk, from our warehouse that we're able to get trade-ins for, right? We had trilogies from Philips that had never been used. We had like 30 of those. We got Getting to give us like 40K just to take them out of our warehouse. Saved us money on disposable costs, and it gave us a nice discount on a new purchase. So you've got a lot of opportunities when you're standardizing your fleet as a whole. 200% year-over-year growth. Our HTM team is probably managing well over 20 million yearly now. So we've taken over bed stretchers, infusion devices, patient monitoring. We're looking at taking over some respiratory. This is money that every regional CEO is saying, all right, you guys can have this. We don't want to deal with this anymore. We don't want to have to make a decision on who gets what. Take care of this for us. You get a couple of years of that, you build that trust, and then you find that you have a lot of power to make some change. Part of that is the reduction in hours. So we've cut the time in half, right? Our old capital process, regional leader asks their department heads, who ask their managers, what do we need to replace this year? Everyone reaches out, usually to the biomed shops, right, individually. Then they would all come bug me. I would give them history on all the devices, and then thousands of people would put all this data back up together, come up with their own plans, and throw it in our capital planning system. And then we would come in, the bad guys, and just Chuck Norris kick those plans right out of the air for them. And everyone's mad now. All this time was wasted. Well, we bring that plan to them. We show them what their fleet looks like, and we say, here's your risk. Now, we can't say you can replace all this, but this is our recommendation. And we're being honest and open about what's going on. And physical therapy finally gets their day on the soapbox too.
I will say that there isn't a CFO on the planet that wouldn't kill for that kind of information, because even if they make the decision to not replace something that's on that recommended list, at least they know what the risk is of not doing that, right?
They know.
Yeah.
Because you're going to have to make a decision. You're not going to be able to replace everything, but identifying what that financial risk is. It does, and it's having enough data and having it presented in the right way just prevents a lot of that emotion from coming back up. This is what it is. Let's figure it out together, right? Travel savings as well. So forecasting those hours out is great, but with Ames, you've got a PM schedule is a little separate. So we were able to forecast that out. We have a lot of field service techs that handle all of our clinics and then some of our external clients. We keep our in-house shops at the main hospitals. Well, you start to see your PM schedule and you see that they're going to this clinic for a couple devices and they're going at this clinic for a couple devices and then they go back to that clinic next month for a couple more. You start stacking your schedules up. A little tricky with ESC, you got to slide it back. You can't really wait a little extra longer. So we were able to slice off 200K there, made everyone happy.
All right, lastly, we want to talk about customer satisfaction. And as I said, of the two metrics I think are critical, cost service ratio, customer satisfaction. So this was a sample, the final question on a 12-question survey that we sent out annually. We actually had the folks that did our patient satisfaction surveys help us create this. And they know a lot about effective surveying and were immensely helpful in creating this. But what it comes down to is what do you want to be? What level do you want to achieve? And so I always recommend that you include words like excellent and exceptional if that's the level that you want to achieve. So that if you get, so here the mean is 4.15 on a 1 to 5 scale, that actually means something. But we surveyed everything about our operations. So the call center staff, were they courteous? Were they helpful? Did they get you on and off the phone in a timely manner so that you could get back to taking care of patients? Our technicians, were they timely? Were they courteous? Were they competent? The management team, were they effective? Right. So all of these things about our business that we surveyed. And we took the results of those surveys every year and created an action plan to help us improve year over year. So this last question, please rate the overall quality of services. So that's sort of like an aggregate, but if you go to the next one, this actually shows you year over year the evidence that we did continue to improve. So year one, we're at 3.89, year two, 3.94, year three, 4.09, and year four, 4.15. So again, if we think about why do we exist to provide optimum equipment availability and serve the clinicians that are taking care of patients. That is critically important work. We need to look at it as being important and deliver the highest quality service that we can deliver. And this is tangible evidence of that. So again, I mean, that's at the top of that curve, right? So you employ all of these steps and you stand a pretty good chance of providing optimum service at an optimum price point.
1 and 2 are worth it.
Yeah.
It sucks, but it'll be worth it. I promise.
Okay. Questions?